I'm sworn in.
No.
So, what I would expect, number one, all these people have endocrine labs pre-op. They all have visual fields. All of them have ophthalmology evaluation. So you should know when this patient comes here if the patient has a field cut. Would you think this patient would have a field cut? Smash both sides. Did she have a field cut? No. Should she? Yes. Okay, smash both sides. Y'all know how to do field cuts, right?
No, we want you to show us.
Well, I want you to sit up because I'm going to show you how I do
Pardon me,
it.
pardon me.
Yeah, where y'all can see. Now, your patient's not going to sit up, so you're going to have to improvise. But before you come in here, you're never going to have an alteration level of consciousness, you're never going to have any motor weakness, ever. It's a pituitary tumor that should wake up like everybody else. So anyway, if I'm in the office, this is just a gross way to do it.
So I'm not worried about their hands or their
No,
feet
you
or...
can move everything. Yeah. You're not worried about anything. Why is that? The pituitary gland is not up into the brain. So I would never expect any motor weakness. Ever, ever, ever. Ever. Never expect any level of consciousness change. Ever, ever, ever. So she comes back. Number one, she's awake and alert. She's groggy from anesthesia. We would expect that. She moves everything, follows commands. That's it. Can you move everything? Yeah, wiggle. Okay, you're good. So,
Okay, now they asked me Q1 hour, like I don't have to worry, like I do my initial neuroassessment, but I don't have to every hour make them squeeze my hands or move because I'm not interested in that.
no, I'm interested in her vision.
Okay.
If she has a hemorrhage in that pituitary gland, and if you look, we go up through the nose, through the sphenoid sinus, through the cribriform plate, and we have a hole and we look at it, and we take a little ring curette, and we kind of ream it out. So it's not like, and her tumor was already through the sphenoid sinus, so we ran into that before we even got there. So, but you're reaming out, okay? And y'all have about the anterior and the posterior, so you're reaming out, and it literally falls out. Just like you're reaming out, what do you ream out? Anything, just like you stick something up there and you ream it out. So, never would have an alteration in consciousness. If she hemorrhages, she will go blind. Okay, so that's why you've got to do visual acuity and you've got to do visual fields. Lay back because they're going to have to do it laying back. Okay, I'm sorry.
No, it's fine.
Okay, so number one, I've already read her H&P to see if she has a field cut. If she has a pre-op field cut before, she's going to have a post-op field cut. Okay, I'm also going to, if they're groggy from anesthesia, I'm going to say, how many fingers do you see? Cover each eye, how many fingers do you see? And that's my visual acuity until I get her awake enough to read the little card. And you have to cover each eye to do it. That's acuity. That's not visual fields. Visual fields is, look at my finger, how many fingers can you see? Look at my finger, how many fingers can you see? That's your visual field. If she has visual field from the pituitary tumor, she will have a bitemporal immunopsia, meaning just on the outside rim. Not like a stroke, will have a homonymous immunopia, one-sided or the other. Hers will be bitemporal just from where the optic chiasm is compressed. So, visual fields, if she had it before, she's going to have it after. Visual acuity, if she hemorrhages, she'll go blind. So I'm going to just make sure she can see. Now, what's the next thing I'm going to look at? Somebody raise their hand. Huh?
Or output.
Exactly. Why am I going to look at her urine output?
Or DI.
DI. And what's the first symptom of DI?
Dumping urine.
Nope, wrong.
Wrong.
What's the first symptom of DI? Huh? What'd you say?
Dry mouth.
You're close.
Thirsty.
Thirst.
But you don't, but that's distracting because after surgery they're thirsty anyways because
No,
they give all those
thirst
medicine.
that you cannot This is gonna be at her
When?
bedside. Every pituitary tumor should have this full of ice water at their bedside. Now, how do you differentiate between post-op diuresis and DI?
Post-op diuresis doesn't happen right away, it's
Right,
about
12
4 to 8
hours.
hours.
Okay, good. What else?
Their K starts to go up. And, I mean, their sodium.
Sodium will not change with post-op diuresis.
So sodium stays the same.
Sodium stays the same. So, I've already just quickly assessed her vision, visual fields, looked at her urine, that's number 3. I've already filled this up with a straw at her bedside so she can get to it. Tell
Could
me
you have
if
a
you
straw?
get thirsty.
Could you have a straw?
Yeah.
What is the
You can't
thing?
blow their nose.
Oh,
Or
okay.
stick anything up their nose.
Because we heard no straws one
Well,
time.
yeah, one doctor,
Some will write no straw.
they learned this like in pre-op, that they weren't supposed to drink out of straws.
You know why?
Well,
It gives them gas,
Oh,
okay?
Guess what?
That's why.
okay.
We don't let our back surgeries drink out of straws because it gives them gas.
Gotcha.
Stupid. How can you drink out of a cup and not douse yourself unless you have a straw? Okay? Some of the newer guys doing the pituitary tumors will not put packing in. But most of them have a tampon shoved up their nose, or they call them tampons. They're not really tampons. It just looks like a tampon that's shoved up the nose. Okay? Should they have a bad headache? No. Should they have pain here? Yeah. They should have pain here. Just got some pain. They can see their urine. What's the specific gravity of water? Water. Come on, y'all.
1.0.
1.0.
Bam!
Bam!
You studied.
So, I usually, if you look at the urine, if it's yellow, she's not in DI. If it looks white, she's in DI. Okay?
Even if she's not putting out a lot?
She's going to be putting out a lot if it's white. If it's clear, she's in DI. So the first thing we do, are you thirsty? Right? Second thing we do is, we don't do specific gravities here anymore. We used to in the old days, spin.
Yeah.
Check her labs. So I'm going to draw sodium. Usually it's 350 for 2 consecutive hours, but most physicians will put what they want to call about. If you keep up with her intake and output, her sodium will remain normal. If you get behind, she can die from hypovolemia. Okay, so, vision, DI, and DI is not really a complication because the arachnoid is right at the posterior part of the pituitary, and it's like tissue paper. So it's real thin, so it's not unusual to get a hole, and spinal fluid goes the path of the least resistance. And it can be a pinhole. It doesn't matter where it is in the body. It's going to be at the path of the least resistance. So what else? What else am I looking at? I've already checked her sodium, and it's normal. I'm going to keep her water jug filled up. Okay? She can see. Pain's not terrible. Visual field cuts aren't any different than they were pre-op. What else?
Are you looking just for like dehydration type stuff, like
Mhm.
Like
skin
vital
changes,
signs.
Absolutely.
their skin
Absolutely.
turner, that type of stuff?
Absolutely. Somebody's, if they're diabetic, you want to be checking their blood sugars just like anybody else. Any other post-op patient that comes in here. So this patient should never have between urine and legs, everybody moving anywhere. Can you see, and you're chasing, and you're in here every hour. If you go to lunch and you come back in here, you're thinking, and your bag is full, not the meter full, but the bag is full. It's like, holy moly. So you can't go to lunch when these people are in DI because you're going to be running to make sure that they have enough fluid on board.
Well, Dr. Bailey sent an email the other day that said we missed a couple of DIs recently on some neuro patients.
Okay. Who's going to have DI? Anybody but pituitary tumors?
Mm-hmm.
Head injuries. Brain death. Those are the only 3 patients that are going to have DI. Brain death, once you squeeze off your thalamus, you go into DI. Brain death, you're trying to save the kidneys, you got to treat it. If they're an organ donor, you got to treat the DI.
What about a craniotomy? Should we look
Never,
for
never
DI?
should have DI. Never. Now,
Now,
what they will have is SIADH.
Okay.
They'll go into SIADH if they have a metastatic lesion to the brain and they have a oat cell to their lung. So a lot of those will go into SIADH. So in the pituitary lecture, urine osmolality, real important. You think if your urine's dilute, the osmolality is going to be what? In the urine. Below. If in the blood, the eye. So, a lot of, and don't forget the hormones. If they're on steroids before, you better darn should make sure they're on steroids after, because they'll go into an Addisonian crisis. So, what is the most common kind of pituitary tumor? What's it called? Prolactinoma. That's most common. In women, it causes galactorrhea. It causes
Breast.
milk out of the
Milk
breast.
out the breast.
It causes amenorrhea. And most of these people we find out because they're trying to get pregnant. And they come in and they have a little pituitary tumor, is a microadenoma. A big pituitary tumor is a macroadenoma. So greater than 1 centimeter is a macro. That's 3 centimeters. So that's a big pituitary tumor. They could not get all of that out through the nose. They just couldn't get it all out. So what else as far as pituitary
What did this
tumors?
lady present with? If she had completely compressed her optic nerve, she had no visual
No
field
visual
cut.
fields, but she
So-
should have.
So what brought her in?
What brought her in, she went to ENT because she had a swollen lymph node. And they just did an ENT of her sinuses and found the pituitary tumor in the ethmoid sinus. And then, and she, all her hormone levels. So the microadenomas, the small pituitary tumors, we'll treat those with bromocriptine if it's a prolactinoma. But you can't treat the other kind of tumors with bromocriptine, only prolactinoma. And if you don't take out the tumor, they probably aren't going to get pregnant. And these are young females.
I had a Dr. Bailey patient, I don't know, 2 Fridays ago maybe.
Okay.
I came on shift from night and he was already down 5 liters. I come on, I let him know first thing, summer, and then by the time 2 p.m. comes around and Bailey comes around, he is down now 9 liters since yesterday's surgery. This was not a pituitary tumor.
What was it?
I think he had a subdermal or something because I think he had a drain in. I
Subdermal?
can't.
Oh, 25?
Yeah.
It was,
What was
he had a subdural and he did have a drain. He was the one from
He
Mount
was
Pleasant.
The chronic. They
Chronic,
Oh.
He had
acute
a-
on chronic.
Acute on chronic subdural, and he'd been having something since January.
Since
and they finally
January,
did
he
his
had a
surgery.
headache.
Headache, right? Yeah.
No.
But is that like
What was his sodium?
fine? All his labs came back fine. We consulted endocrine, and they were like, we don't. Dr. Bailey's like, I don't know really what's going on, and neither did they. They're like, it doesn't show signs. This doesn't match anything. So
Right.
is this abnormal? Like something like that, I guess.
Yeah.
Kidneys. That's the first thing you want to think about. You can go in a DI
That's, I think
from
that's
the
one of the
kidneys.
ones that we missed that he was upset
The
about.
kidneys.
Is that we missed the
You
DI.
can
No.
have,
No, that wasn't it.
What?
Well,
One DI.
they called him that night and he did not care.
and you shouldn't
It
go in a
wasn't
DI
him.
with a subdural.
Well, I know, but they were just calling him because on the order said if urine output is greater than 120 for 4 hours, they need to be notified, period.
That's less than 120 for 4 hours, I thought. Is it greater than or less than? Because 30 an hour is normal,
I don't know.
and that's just... should be-
Average or greater?
30 an hour is kind of average. But why was he dumping urine? There's another reason why he was diuresing, and it was not DI. Okay, so you got to know what's
But
wrong
sometimes
with your
we'll
patient.
get told by Summer or one of them that they got mannitol in the. In
How
the
long did mannitol last?
I don't know, but that's what we get told.
Well, mannitol doesn't last. What is the half-life of mannitol?
That's an hour? 30 minutes.
Okay. You got
But
mannitol
don't. I mean,
4
am I
hours
making that
ago.
up, or don't they
No.
tell us that
Yeah,
sometimes?
the-
Okay, I
No,
just want to
they
make
do.
sure. What
You
we
get
get.
mannitol 4 hours ago in the OR. You ain't gonna be still diuresing. I want to know what his renal function is because it's not DI.
Okay.
You know,
Yeah.
something else is going on with the patient, and it's probably metabolic, kind of. So I want to look at the, creatinine clearance and all those to see if his kidneys are functioning.
You look a little too
Go ahead.
comfortable.
I have, so we've got the patient that's the transvaginal surgery that was on yesterday.
Yeah.
And like at first she was dumping a lot of urine, it was like 250. Well, then she hit and she did 350.
Okay.
Well, then the endocrinologist had come in and then he said that if there was any problems to call him. So we went ahead and called him. And he said 300. He didn't say 350. He said so if it was greater than 300 for the next, 2 hours.
2 hours.
Then to call. So, I mean, is it set? Because I didn't look at the
No.
sheet on there. So,
No,
I
I'll
mean,
come
300,
in.
350. I mean,
I'll come in and look at it, and I go, that's still yellow. Most people in true DI, it's going to be way more than that.
okay.
Way more. I mean, you're going to look at it and you're going, well, I'm behind the 8 ball about 3 hours. I got to catch up.
Right.
So if you can get,
if you had it for 2 hours and it was still yellow and it was 300,
I'm going
Would
to
you
check a
say-
sodium.
just
Check the
yeah.
sodium.
So, do you think we could just go ahead and do that, or
Let me
that's
tell you
what we're gonna
something.
be-
If you give DDAVP and they aren't truly in DI, you will kill your patient. Okay, so before you give somebody DDAVP,
Why?
number
Because
one,
it causes water intoxication then?
yeah,
Yeah.
Because we
Shuts
usually
down
give
the
it.
kidneys.
They give it.
shuts down the ADH, and so they get no ADH. And then they go opposite, they go into SIADH. So instead of having urine, you have none.
Oh,
You have no urine.
I don't have
And then
that.
your sodium goes opposite.
I brought them in here.
And then you have a seizure because your sodium goes to 120. So before you give DDAVP, number one, you better make damn sure, excuse me. Am I on video?
Yeah. It's just
We can
us.
edit it.
It's just us.
Just
Minute.
compassionate.
Make darn sure you know what their sodium is. You know for a fact that they're dumping and they're thirsty and you know all this. So just, it can be a challenge because you're running around keeping up with the urine output and the intake. And in the old days, we'd match it. We'd match urine output, match it 1-to-1. And a lot of the old guys still will do that because nobody can drink a liter of water every hour. I mean, they can't do it. So a lot of times we used to match the urine, the output with the IV fluid.
Can you show us on those 14-inch things? Like you said, before I really wake up and can see, well, you're just going to see how
I'm
many
just gonna see
fingers.
if they can
But
see.
can you tell us about those things?
Do you
with
have
the
your card?
strings And a card?
I have a card.
What?
Was their field cut ever come back?
Yes.
Because they ask that a lot.
But
like, they
not-
have
Well,
it.
I brought the whole stack in, but if you want to go get that one, I don't know what I did with the whole
There's
stack.
no guarantee. See, I don't even use it.
Oh wait,
That's
she's
how-
got one.
Well, she
She's
doesn't
got
have
one.
with the string, though. We need to be able to.
I
No,
don't care. You know what is this?
that's what I
From
said.
here
Just
to
arm
here.
length,
What is this?
I don't know.
You should know what this
about
is.
14 inches,
There you go.
About 14 inches.
unless you have Marfans. Then it might be a lot more inches.
So
Yeah.
this.
Can you see it without your glasses? No. Do
I
you
can
wear
read.
glasses?
I'll tell you where I can read. I
You need to
can.
cover one eye.
I can read the 95.
Put your glass, so you gotta know if they wear glasses, if they have contacts. You have to know if they can see to start with.
Okay, 374258.
Alright.
So that's 2030. Is that what I
That's
document?
fine.
Is that what I document?
Yes.
Yeah, visual. What do you write? Like
Visual acuity.
20, 30, right eye.
There you go.
Visual acuity, whatever, left eye. Okay. Because it's really not clear in our current documentation
374258.
system where to document that.
Well, you've got to miscellaneous that.
Well, that's what we're going to do.
You have
Well,
to
see,
miscellaneous.
that's what we need to know, because we've been missing this for a long time, so we're trying to figure out. So every hour, I need to give them this, and I need to document right eye, left eye, 2030, 2040,
Absolutely.
2020,
In
whatever it
between
is.
catching up with their urine output.
For how long do we do the visual acuities?
If you went over
I would say
neurochecks.
48 hours at least.
Every hour?
Every hour. Oh yeah, they'll go blind. They'll start losing acuity, and then, maybe they just have some swelling. Maybe they have a little bleeding in their pituitary gland, but their visual acuity will drop.
Do y'all make them cover eyes, one eye and the
One
other?
eye and then the
Do y'all
other.
make them do that, or y'all
We-
do
Do you
it?
carry?
You do? Do you do that, Andrew?
No, I do not right now.
You do now,
I
don't you?
would, absolutely.
I don't
Okay,
think
so
we.
ear to ear. That's a
Yeah,
good. Nobody has to
I
have
do
a
the
ruler.
peripheral vision, and when can you see my fingers? And then if they can't on one side, then you know something's going on. Andrew,
What?
when you're doing the peripheral vision,
Oh.
then that brings it to your attention that this eye isn't seeing as well as that eye, and then you'll start asking them to cover.
But you
But
didn't do it like this. You just did here.
That's right, because
See,
that
she
is
didn't-
not acuity.
Well,
She just.
That's
I'm still gonna
visual
do a
field.
neuro
Only
check,
fingers.
Remember, that's not acuity,
but I'll
that's
still do
visual
a neuro
field.
check.
So if they have a field cut,
I'm still gonna
if
do a
they
neuro
can't see half of
Right.
their vision on lateral,
Right.
then you're gonna have to get them, you're gonna have to move that card to where they
to
can
where they can
see
see
it.
it.
Oh, okay.
Okay, so if she has bilateral field cuts, then
not
she's
gonna
not gonna
see.
see,
Right.
she may not see midline. You're gonna have to move it medial.
Front.
But that's my question. Do you
That's
have to
still
do those fingers like this until they can see them? Because you only held them here for me. But do I need to do it?
But
till
you'll
I-
know that from the pre-op.
I know
That's
that.
it'll be that way pre-op.
Homonymous immunosis.
Well, that's what I want to know.
And I think it's very important that when you get your patient from post-op, that they do the neuro check off.
Now,
'Cause
what
that
I
helps
do in
indicate
the office, sit up, what I do in the
when you
office
start.
is I do all the visual fields.
Mm.
So, but she's sitting here looking at my nose, and I'm gonna have her cover one eye, and I'm gonna, if she's looking at my nose, and I can see it,
Mhm.
then I know she can see it. So that's visual fields to confrontation. So I'm gonna say how many fingers? How many fingers? How many fingers? So I've done all three divisions, and then the same on the other.
Okay.
But she's got to look at my nose because we're checking the visual field.
They
Sometimes
cheat.
They cheat.
They
Also-
cheat.
Can't get them just to look at your nose. You know what I'm
Yeah, they
saying? They
cheat.
keep looking over.
And I tell them in the office, you're cheating. You're cheating. And then another thing, that lady with the big tumor, we're going to check the sensation in her face. We're going to check the trigeminal nerve. Because the trigeminal nerve goes out right in the anterior skull base. So I'm going to just make sure she can feel me. All three divisions.
Oh, I have a question.
Oh, Lisa. We pick
And
Lisa.
y'all didn't know that.
Cindy,
Check the
when
trigeminal nerve.
you're doing like an assessment and there's a differential diagnosis between Bell's palsy and a stroke,
Okay.
isn't it true that in Bell's palsy you can still innervate the nerves up here, but you can't in a stroke?
Bell's palsy, what does that include?
Cranial
The
nerve.
facial nerve.
The
Yeah.
facial
What does
nerve.
that indicate? Upper face. Whereas a stroke is motor, which is lower face.
So is that true that they can, you can raise your eyebrows bilaterally with Bell's palsy?
I don't know.
It's opposite?
It's opposite.
there?
Opposite.
Okay.
Bell's palsy, sometimes they can't close one eye as well, right?
They can't close one eye, they can't raise their eyelash, and they may have a little droop, but stroke, it's lower face. Lower face. Should never have an eyebrow that doesn't go up.
Okay.
Okay. Now, she had a craniotomy for a brain tumor. Okay, and so we know where her brain tumor is in our little monitor. we're going to that little quick neuro assessment guide that y'all are all gonna get.
She's working on it someday.
I've already done it, it's at the printers.
Mhm.
She's got a brain tumor. So when she comes back from surgery, number one, I need to know what her pre-op deficits was. Did she have weakness before? So when she comes back, lay back, because now you had a craniotomy. So do I expect her to wake up? Absolutely. Unless she was in a coma before she went, then she may not wake up. But absolutely she should wake up from her craniotomy. So, you know, I've already interviewed her, asked her if she had any pain, blah, 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 blah. Okay, first thing I'm gonna do, she's awake, I'm gonna have her hold up her arms. Hold your arms up, palms up. They stroke people do it wrong, by the way. Close your eyes. Okay, so I'm gonna let her know. She's not gonna drop like this, y'all. If she truly has some motor weakness, she's gonna do this. And a lot of times, I had one in the office last week, all she did was this. That's an itty bitty weakness. So if she's got right-sided tumor, she may have, a left-sided tumor, she may have a right-sided drift. I need to know that beforehand. Okay, so that's what she'll do. And that's my motor assessment. Move your legs, pick up your legs, the other leg. If she's got midline tumor, legs gonna be weaker than the arm. If she's got anterior cerebral stroke, legs gonna be weaker than the arm. Middle cerebral stroke, arms gonna be weaker than the leg. And y'all have all that in your little manual. And that's it. That's my motor assessment. I'm not checking every.
But when you have a cranie, are pupils important or acuity important? What becomes important in cranie that's not important in a transsphenoidal?
Level of consciousness. They should be awake. They should follow commands. They should hold up two fingers. Hold up two fingers. If they hold up two fingers, you know they understand you and they can function. I don't do hand grasp because that's only strength. That's strength. I don't care about her 5'6" cervical. So hold up two fingers. Don't show them. If they don't follow commands and they're wide awake, they have receptive aphasia. And so what I do, if they're aphasic and they can't understand what I'm saying, then I'll let them mimic two fingers, and they'll do it. You know, they'll copy you, but don't show them two fingers. Just say hold up two fingers, both hands. Okay, that's what I'm doing. Pupils, when do you expect a pupillary change? By the time the swelling goes to the midbrain,
Late.
and it's way too late. They've been in a coma for hours.
What about sleepiness?
Sleepiness?
Don't you-
Okay, if you give somebody your heart attack, you gave them 5 milligrams of morphine. Can you wake that patient up?
Mhm.
Yeah. You give her 2 milligrams of IV morphine, you still should be able to wake her up. And she still should be able to follow commands to verbal.
And not just drop to sleep.
Huh?
Not, you know how they get, it seems like when they get worse, they're.
They won't
more
maintain
sleepy, yeah.
wakefulness, so
Yeah.
they become lethargic. So now I have to shake her to get her to wake up, not just verbal. And so that's a change. You need to get on the phone and call somebody and say, she's not spontaneously waking up like she did. And you're going on a road trip. That's significant between Dawn woke up when I called her name, and now she doesn't wake up until I shake her or pinch her shoulder.
I get my
So-
families involved. I ask them if there's a change, come get me. If she starts falling
Well-
But
asleep.
if I tell you, oh, there's a pupil change, but I haven't told you anything else, then I really haven't
You-
done my job because
Yeah.
I've waited
No.
for a long time.
You're going to be blasted, and the neurosurgeon's
You're
going to
going
find
down
out
to
who
see
you
too
are,
that-
and they're never going to trust you again. Never call
Your
about
name
a
is
pupil.
Mud.
If you got a blown pupil, they're posturing, okay? So never call about a pupil. Call about they quit following commands. They quit following command. And in your little,
Can't keep them awake.
they won't, that's right.
Yeah, you know what I'm saying?
They quit following commands. They have right-sided weakness. They quit following commands.
What about ACDFs? Do we get those back here?
Not very often, but.
Not very often.
We get the
What would be neuro assessment different for an ACDF?
As far as
Like what, neuro checks every hour, whatever they ask?
Motor and sensory.
Are they asking for
Sensory
neuro
and
checks
neurons.
every hour on a ACDF?
We don't really get a lot of
And just
those.
airway.
Yeah, I was thinking, because
Just airway.
We only get them if there's an airway issue usually in here, but we get a lot of the thoracic.
Right. The drop,
Lumbar.
the lung, the motor sensory to the legs.
So
Did y'all
the
learn
The
anything?
lumbar,
Yes.
The lumbar ones are more motor centric to the legs?
Yep.
Is there any other neuro patient that we get that we wanna know what our assessment is?
We get a lot of cranies, but,
So when is that book gonna come? So that we
So
can.
I gave it to Lauren's
husband.
husband.
To
I
print.
emailed it to Lauren.
It's
It's
a
already been
small-
done, just a
Is it
little,
small?
Is it like an
quick-
overall
a
of?
quick reference guide, got a little anatomy and physiology, little arteries, you know, for your strokes. She wanted me to include the stroke syndromes, so I included the stroke syndromes. And then I included pituitary post-op, craniotomy post-op, a rapid neurological assessment is the first page. You got 30 seconds to come in here and see if she's gonna die. And I gave you a little rapid neurological assessment, boom, 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 and that's what you tell the neurosurgeon on the phone. You know, you've got 30 seconds to assess this
I have another
patient.
question. You know, since we started the RT, you know, I was always taught, everything that I've done, that the palms are up and you close the eyes and you see if you drift. Now we're being told that, you know, your hands are up here and you do one at a time and whatever else. So why is there a difference?
Cindy
between-
Anderson doesn't know who wrote those.
It's the NIH stroke scale.
I know, but they're
Yeah.
wrong. They don't have
But
people
even
that
on
know.
the, I mean, on the videos and stuff, the videos show with both arms up.
Both arms
Are you
up.
comparing
Palms
left to
should be up.
right, you know? I
Yeah,
mean,
You've
is
gotta
everything-
compare left to right. I don't care. I'm not sure why you do this.
Yeah.
Because I like it better when you have both, because you can actually see them when I stand to the side. I
And
can
you,
tell if there's a
you let them
little bit
do
of
that
depth
for
or whatever.
15 seconds.
Uh-huh.
So you've gotta do
On
it
the
long
NIH, it's
enough.
only 10.
10 seconds.
I don't care. They do it wrong too. They do this.
Well, if they
She
should
has
what?
to
do this.
I was, huh?
No, because the way she said that the palms can be this way, but the way that I've always learned was.
It's palms
I
up.
thought- I always thought it was palms.
Palms up.
Yeah.
Always.
But when we did our review, you know, when she came around and did the review, I mean, it was like this, but it was only one hand at a time. And that was the quick assessment there,
Yeah.
so.
How are you gonna compare if they're weak? What if both hands go down?
Well, because on the paperwork, it has right arm, left arm,
No.
and you score each one, that's why she's asking you to do it that way.
Right, but I'm just saying, is
But
this
it's
a
a
lot
lot
before
easier
that, we
to
did
see.
both of them. Yeah.
Dr. Sparks, the neuro hospitalist.
I may need to talk to her.
Well,